My research is entitled Machine Learning Models to Predict Healthcare Costs for Patients with Inflammatory Bowel Disease and Irritable Bowel Syndrome. Did you know that Canada has the highest prevalence of IBD and IBS in the world, and that women are more impacted by both conditions than men? Patients with these chronic conditions suffer from severe inflammation of the gastrointestinal tract, leading to rectal bleeding, diarrhea, unintended weight loss, and pain. There is no known cure for IBD and IBS, and as a result, these patients require ongoing medical care. In addition, the number of patients with IBD and IBS in Canada is forecasted to increase and impose an even larger financial burden on the publicly funded healthcare system. Therefore, it's absolutely imperative that we aim to estimate healthcare costs and resource utilization to help minimize escalating costs and facilitate the efficient allocation of healthcare resources for these patients. But the question still remains, how do we go about doing this? Well, in this project, we are going to use artificial intelligence, or more specifically, a branch of AI known as machine learning. ML makes use of statistical methods to train algorithms to make predictions using large databases. The overarching goal of this project is to develop supervised machine learning models to predict healthcare costs and resource use for patients with IBD and IBS. We will also take sex considerations into account and develop sex-specific models to predict any differences in cost and resource use by males and females. Such models will hopefully lead to better management of healthcare system resources for these patients and may even lead to the development of more cost-effective approaches for IBD and IBS patient care. Now, for this project, we already have an available database that was created in 2017 and is currently being updated. We are also using administrative data provided to us by Alberta Health Services. The visual shown indicates the step-by-step methodological pipeline that is being used to conduct this research. I will now talk about each step. The first step is data collection. Now, this project is part of the Imagine Magic study, which is a prospective observational cohort study that is recruiting 8,000 participants across Canada. All participants are expected to attend a baseline visit and several follow-up visits. At each follow-up visit, participants will provide blood, urine, and stool samples and fill out another questionnaire. The information and the samples collected from participants have been used to create the database that will be used to develop the ML models. The second step in the pipeline is to conduct exploratory data analysis on patient data. This has helped to identify features in the databases that can be used to train the machine learning models to make predictions. The next step is data preprocessing, and it involves quality assessment, imputation, transformation, and dimensionality reduction. Preprocessing is the most important step in any machine learning project pipeline because it ensures that the data is meaningful enough to produce equally meaningful models. The fourth step is to develop several supervised machine learning models. The reason we need to create several models is to enhance accuracy and predictive performance of the final models that we will eventually deploy. The development stage involves the 3 steps shown in this image. The fifth step will be to assess the performance of the models using the respective ML performance metrics for regression and classification. The final step in the pipeline is to validate the models. ML models are black boxes, which means that they are not easily interpretable to us. In order to make them interpretable, we can use explainability tools, which do exactly what they sound like. They explain the models to us in simpler terms. All of the steps in the pipeline are critical to ensuring that the models can be deployed with confidence in the future. Now to the results. Exploratory data analysis helped us to pull 60 to 75 features from the patient data to create the models. The features pertain to cost and included the number of hospitalizations, types of surgeries, progression of disease, and reason for hospitalization. For imputation, the missing data was successfully replaced using a combination of complex algorithms listed on the slide. Likewise, dimensionality reduction was done using several algorithms, and it led to the minimization of big data and the removal of noisy features. I was also able to create different types of machine learning models and achieved accuracy scores ranging from 36 to 55%. So far, these models can predict the number of hospitalizations that IBD and IBS patients will require later on. I would also like to stress that this work is still ongoing. Finally, I'd like to thank Dr. June Lee, Dr. Deborah Marshall, and Ms. Karen McDonald at the Cummings School of Medicine. Thank you.